just a little bit about myself, prior to getting going here. I have a wife and a young daughter, so we're happy to be back over here with some family in the Madison area and happy to serve these small communities. I'm originally from Stoughton, Wisconsin, so no stranger to smaller communities, and Stoughton is actually very similar as far as sort of water and how far out we are from some cities. So tonight, as we kind of go through presentation, gonna get things muted. Everything looking good as far as that goes, Kelly?
Looks good to me.
Okay. So we'll kind of go over a couple of things here, sort of just, what we're covering. She kind of mentioned, just kind of general healthy habits, some things that we can move to improve on, some common causes for foot pain as you age that may be slightly different than what you would experience maybe as a younger adult. Shoes and inserts we'll kind of go over and kind of touch on some things to look at, give a couple examples, and then we'll kind of go into a little bit further on the sort of diabetes side and sort of how that affects you as you age and some of the complications that can arise from that. So we'll kind of start just off with some, just general foot habits. This isn't going to be specific to any one person, obviously, but if you have dry feet, dry cracking feet, certainly can happen as we age. As you know, your hair, your skin, your nails kind of starts deteriorating. So if you have dry cracked feet, one that can be a sign of a couple of different things. It can certainly be a sign of a fungal infection. Could be a sign of psoriasis. It could be just general wear and tear and sort of dryness. So here's just a couple of sort of moisturizer and cream type options that are available to us. The 40% urea cream is a great emollient and exfoliant, meaning that it helps break down that keratin, which is that kind of top layer of skin. Great for calluses and kind of thick built up skin, especially at the heels. We have a lot of patients that come in that have had, dry cracked heels or just kind of overall dryness to the bottom aspect of the foot and have tried different creams. So something like a 40% urea or an amlactin helps kind of break down that top layer of skin and help slough it off and sort of maintain moisture. So Certain Dry is sort of a brand name, but some people find that their feet sweat more than others. So again, as much as being too dry is an issue, being too sweaty is also an issue as well. That can lead to skin breakdown, that can lead to bacterial and fungal infections as well. So this Certain Dry is one of those brands that has kind of similar to almost like a deodorant. So that's what that aluminum chloride is. That's in what's in most of your antiperspirants. But they come in a roll-on as well as a cream, just to try to help maintain, if it's too wet, you got to dry it. If it's too dry, you have to wet it sort of stance. Stretching, strengthening, and balance. This is an important one, and it's something I don't think we focus enough on, just even as a preventative health measure. But 13% of people between 65 and 69 report imbalance while walking. The annual risk of falls for adults 65 and over is absurdly high. 25 to 28%. Those falls, obviously as you age, become more risky. Hip fractures, hitting your head, back injuries, wrist fractures. There's a lot of morbidity that's associated with those types of falls as we age. Eyesight, strength and muscle mass, your vestibular or sort of inner ear function, and foot position and mechanoreception all decrease with age. Medications, chronic disease, prior injuries, and even shoes can contribute to some of this risk of falls as well. So, we're talking muscle mass that decreases at around 3 to 8% per decade after age 30, certainly more rapidly after age 50 and 60. Decreased muscle mass is associated with increased risks of falls and fractures as well. So when we're talking strengthening, this isn't necessarily specific to just the feet, but certainly the feet play a role. But higher protein diet, progressive resistance training, this can be accomplished, especially early on if it's something you've not done for decades or have not ever done. Getting a personal trainer or a physical therapy assessment to kind of go through where are your weaknesses, what areas can you improve on, and sort of how to safely perform some of these activities. Adequate sleep and hydration. Everybody needs sleep and hydration for rebuilding muscle mass and just healthy tissue healing in general. And then swimming and water aerobics are another sort of great strengthening and aerobic exercises, and particularly particularly with the aging adults, on a lot of our osteoarthritis, can certainly wreak havoc on joints. So swimming and water aerobics is certainly a great option and easy on the joints. Balance. This is another one that's extremely, important throughout the day. So, as we said before, balance can lead to falls, and balance can be an issue with eyesight. It can be the inner ear. It can be your inability to sort of feel the ground, as I stated, your receptors in your feet that kind of tell where you are and how much pressure you're putting on any given part of the foot, starts to deteriorate as you age. And you can actually see these are, a little bit older folks, and they're barefoot doing this, and actually being barefoot a portion of the day, as long as, barring any sort of significant deformity, especially when doing these types of balance exercises, is actually great from an elderly standpoint to work on that sensation in sort of where your foot is in space. And then again, finding moments throughout the day. So this is something I do. It's something I recommend to a lot of different people, especially if you have a history of falls. But when you're brushing your teeth, a lot of time you're standing there, you're looking at your phone, you're just looking at yourself in the mirror. Very easy. Stand on one leg for a minute, stand on the other leg for a minute. You can certainly hold on to the countertop if you do have some instability in that. But it is really important, your balance as you age, certainly from not only a fall perspective, but just as an overall health perspective. So something I typically recommend for people. Stretching. Stretching is another big one. None of us do it nearly as much as we should, but a tight Achilles tendon leads to increased forefoot pressures, can certainly lead to stress injuries out in the metatarsals and in the toes, can lead to calluses, it can lead to arthritic midfoot pain, plantar fasciitis. It's quite a list. In the world of foot and ankle, we kind of say Aquinas, which is a tight Achilles, is kind of the root of all evil. It sort of contributes to a lot of different symptoms, and a lot of times when we focus on certain pain points, we certainly look at stretching as kind of a main focal point of it. Typically 15 to 30 minutes a day. This doesn't have to be done all at once, but typically you're going to want to hold at least a 30-second to a minute stretch on any given one. And again, these are just some overall options as far as sort of different abilities to hit different muscles. The gastroc muscle, I don't know if you guys can see the pointer here, but your main calf muscle that crosses not only the ankle and the subtalar joint, but also your knee as well. So different stretching, including straight knee and bent knee, to sort of activate the soleus, which is the muscle underneath that calf muscle that combines with the calf muscle to form the Achilles tendon. So performing some of these exercises with a bent and a straight knee can sort of activate different muscles and stretch different muscles, and again, alleviate some of those pressures out in the front of the foot. That in turn can lead to decreased knee, pressure with walking as well. You just become a little bit more adaptable, a little bit more mobile, sort of better shock absorption, if you will. So what are some common causes of foot pain in elderly? There's certainly plenty of foot pain that can happen throughout your life. These are just kind of some of the main ones that we see kind of as you age. Arthritis. And arthritis is kind of a vague term. I've kind of thrown up a couple of different ones here. But osteoarthritis is kind of that general wear and tear. Post-traumatic arthritis would be in the ankle joint and in the foot. Ankle joint specifically, very common for ankle arthritis to be post-traumatic, prior ankle sprains, prior ankle fracture. Whereas in the knee and in the hip, it tends to be more just osteoarthritis. It tends to be more just wear and tear. There's certainly rheumatoid arthritis. You can have gouty arthritis. There's an extensive list. So arthritis is sort of a vague term, but a lot of these, tend to present later in life. It results in stiffness and pain, sometimes alleviated with activity, not always. Sometimes that arthritic pain is just there throughout the day. Sometimes it's a little bit worse and a little bit better depending on what you're doing, but certainly can lead to that swelling and stiffness and pain. And again, with the variety of the types of arthritis, treatments certainly depend on sort of the location of the arthritis as well as the severity. Inserts, stretching, rigid shoes, or sort of a rocker bottom shoe that would allow the shoe to take more of the force and do more of the action for you than your foot. Carbon fiber plates, again, similar concept as rigid shoe, basically having the shoe do some of the work rather than your foot bending through those arthritic joints. Injection and surgery as well is an option. Fat pad atrophy. The only time we really see this in in younger folks would be after sort of heel fractures, if you disrupt that heel pad on the bottom of the foot. Otherwise, this tends to be just a wear and tear age, especially if you're very active or been on your feet for a long time, very physical jobs. Basically, it's a decreased compliance and thickness of that fatty cushioning at the heel, as well as underneath the heads of those metatarsals out on the front of the foot, the ball of the foot, if you will. Again, treatment ranges from cushioned shoes. Increased cushioning certainly increases the, decreases the pressure that goes directly to those areas. You can get gel pads or cushioning pads. Avoidance of barefoot walking. So again, this would be one of those ones where we talked about with balance and kind of stretching in that, and how for some people it's important to have that sort of foot ground mechanical reception to know where your foot is in space and sort of how it's functioning and increase your balance. Some people are just unable to go barefoot, and that's okay too. There's different options then as far as shoe gear goes that can sort of accommodate people who are unable to go barefoot, especially on, most people's houses are sort of wood flooring or, tile and that. So that can be quite difficult on your feet. There is also something known as fat grafting or Leniva. Basically, it uses an allograft sort of fat solution, and you basically insert it into the foot underneath the fatty layer, within the fatty layer of your foot, to try to increase cushioning from the inside, and sort of rebuild some of that fat pad atrophy. Not done all that often. Back in the day, they used to inject silicone, and then they found that they were having a bunch of problems with it. So now it is more of a sort of an allograft where they take fat from somewhere else. But it is an option that has been out there. Stress fracture, stress reactions. These are, again, really common as you age, especially in the setting of osteopenia, osteoporosis. You have that decreased bone density. They can lead to breaks in bones with normal stress. So insufficiency fracture, what these are known as, basically your normal stress, you're walking around, but your bone just has a decreased ability to sort of handle that stress. Whereas athletes or, people who have normal bone and have an increased stress, people that join the military and they go from somewhat sedentary to running a lot, those are more known as fatigue stress fractures. But certainly with decreased bone density as you age, we do see these quite frequently. Corns and calluses. So we sometimes use these interchangeably as far as terminology goes. Corns would be similar to callousing, but they tend to have more of a central core that can become quite hard. They tend to be, again, on sort of prominent areas or weight-bearing surfaces, and it can sort of feel like you're walking on a small pebble. Calluses tend to be more diffuse, but again, they both develop in a way that basically there's too much pressure to a site. So it's usually, with a decreasing fat pad or underneath the metatarsal head or the heel. Some people will get it on if you notice, some people have a fifth toe, a little baby toe that sort of curls in, and, maybe they're a higher arch, so they're walking more on the outside of the foot, and they have some callousing that builds up sometimes around that nail, just because it's an area that's not normally supposed to be weight bearing. Same with the tips of the toes. If you've got bad hammer toes, you've probably seen some callousing at that site. Typically treatments involve, again, one of those urea creams or the amlactin cream, again, to try to break down some of that top layer and keep them soft. And then certainly offloading or cushioning with pads or inserts. Ingrown nails, we see a lot of these. Again, as people age, nail changes happen naturally as you age, just standard with decreased regulation of keratin, decreasing circulation, chronic diseases, poor fitting shoes for long periods of time can also affect these and make them worse. Curving of the nail as the male natrix cells are damaged. Again, that can be due to the ill-fitting shoes. It can be due to decreased circulation. It can be due to diabetes, smoking, what have you, psoriasis. There's a lot of different causes. And treatment, again, kind of depend on what exactly is the cause. But typically routine care, cutting the nail straight across, unless you do have significant curving, like in that picture up top, I would actually recommend in those settings that you sort of cut the edge back and effectively lengthen or straighten the nail, rather than having the corner kind of really dig into the skin like that and have a sharp point. There are procedures that we perform, both partial and total nail avulsions. Partial just meaning we're taking effectively one side or the other, a portion of it, sometimes both. and then a total nail removal. You could have the entire nail removed. For people that have just really thick nails that are difficult to fit into shoes, they're very painful. They have a history of, prior injury, or just, the nail just has never grown back in and they get these painful ingrowns or infections. We typically recommend just removing the entire nail. And that can be done with and without a chemical. That chemical kills off the nail cells that grow the nail. And so you either end up with a portion of a nail that doesn't grow back, or you end up with an entire nail that doesn't grow back. And for some people, that's a great option. There is something known as OnifX. These types of devices are basically, it's sort of a metal that wants to maintain, it's got memory to it. It wants to maintain a straight sort of lie to it. And what you do is you glue that on in a curved fashion on your nail. And as your nail grows out, that force from the metal wanting to be straight sort of helps pull up the edges. Now, when you're talking toenails, the big toenail can be anywhere from, on the short end, 9 months, 12 months. For people with age, in poor blood flow, those numbers can be quite a bit longer, up to 18 months for an entire nail to grow for the big toe. So it's a long process. Luckily it's something you sort of glue on and let it grow out. It's not something you really need to maintain all that frequently. But it is a viable option if, for say you can't have a procedure, or it's a high risk procedure. If you have poor blood flow and the risk of doing a procedure and doing a chemical burn would potentially cause a bad infection and ultimately amputation, there are other options available. But again, kind of specific treatments sort of depend on we do sometimes take cultures of these as well, but kind of depends. The specifics obviously would need a formal evaluation. So when we're talking shoes and inserts, it's very important to find the appropriate size shoes. There's a lot of people that I've run into throughout training that have said, for the longest time I've worn size 9. And then they go, oh, all of a sudden I went and got fitted and I'm actually a size 9.5 or 10. Now you can have some widening and lengthening of your foot as you age, again, as your hair and nails and skin sort of relax and sort of break down a little bit. Your ligaments certainly can as well. And it's also not uncommon to have 1 foot wider than the other, or 1 foot slightly longer than the other. Some people do require a half size difference between shoes, which again makes it difficult because they don't normally sell them that way. But typically when you're finding the size of your shoe, this is sort of an old school device. It's still used today, but I don't know that many places still have these. It's a Brannick device, which again measures your width and length. Very important to measure this when you're standing, again, because as you stand, your foot will splay out a little bit. So if you are going to get your foot measured, you do want to make sure that they have you stand feet shoulder width apart and sort of equal weight on both, and not just, while you're sitting there putting your foot in it. As far as finding the right shoe, you do have to determine sort of, what style or what need of footwear do you have? Is it more of a walking shoe? Is it more of a hiking shoe? Is it more of a running shoe? Or sandal, etc. So different shoes are built for different tasks. Just like, for tennis, you're not going to wear a soccer cleat. You're not going to wear a soccer cleat in football. These are specifically built with reinforcement in certain areas because they require different things of the shoe. And then also knowing your foot structure. So you've probably been somewhere or seen the sort of pressure plate deal that you would step on. It basically is mapping out what you're seeing over here on the right. It's mapping out how much of your arch effectively is touching the ground. And that tells you where you're, whether neutral or kind of flat foot to really pronated to really high arch. And that's important. We can do that on physical exam as well. And with x-rays, sometimes the foot will actually look relatively normal, but you'll have sort of a different plane of flat foot or a different plane of high arch. It's not always just this side view that we're looking at. But again, foot structure sort of dictates what shoes are beneficial to you as well as what inserts are beneficial. So again, high arch tends to be more rigid, tends to have a lot more pressure over on the outside of the foot. As you can see, there's certainly a lot less surface area. So the less surface area means increased pressure for the areas that are touching. So people on the far right over there tend to have a lot of pain underneath the 5th metatarsal head, so behind the baby toe as well as the heel. So those tend to need more cushioning. Now, that doesn't mean they don't need arch support. Again, that would be a specific determination on exam, whether or not they actually needed arch support or if they could get away with, simple cushioning. And then a low arch tends to be more flexible, again, which just means they need a little bit more stability. And again, these are all things that would sort of be determined on physical exam, but as well as a pressure plate if you happen to go to the store and wanted to look. As far as brands of orthotics inserts, there's all sorts of them. I've thrown up a couple of the ones that are kind of the most commonly recommended. So Superfeet, Power Steps, Curex, Spanko, Dr. Scholl's, as well as custom orthotics as well. They come in all sorts of various sizes, arch height, materials, different amounts of control of the heel. That's what most of the orthotics are doing, are controlling your heel as well as distributing some of that pressure from basically including it into the arch if you're a higher arch person with cushioning, as well as raising the arch or trying to give some level of normal neutral positioning if you're a more of a flat foot style. So I tend to recommend Power Steps. I use them myself. They're probably the most recommended by podiatry all over the world. That's not to say they're the best ones. That's just the ones that we have the most experience with. Superfeet are great as well. You'll find them a lot at Fleet Feet if you go there. I believe Fleet Feet also utilizes Curex. Spanko, in my experience, has been sort of an over-the-counter, so you could find them in Walmart and such like that. Dr. Scholl's, I think most people are familiar with. They have upgraded to having more arch support. They have historically kind of just been a simple gel coat for cushioning, but they have made some modifications and do have, again, similar with the rest of these, with different materials, different control, different sizes and that. And then again, you can see there's inserts even for, sort of these higher heel wedge type shoes, just to provide some extra cushioning as well. So all sorts of different things that you can put in your shoe. Again, which one is right for you probably needs an examination. But some of these places do have those foot plates and can sort of recommend based on what your foot structure is. And so again, kind of choosing the right orthotic and insert, it really depends on your need. It's certainly not a one size fits all by any means. Same with shoes. It is very personal. Your orthotic should match your arch. If you're sort of a neutral to a high arch to have a good effect, you want to make sure that when you have that, if you have your foot up on the side and have that arch or have that orthotic meet your foot, you want to make sure that there's not a big gap between the arch and the orthotic itself, because then it's not being utilized to the best of its ability. Your arch is still doing more work than it would necessarily need to. And low arches need to obviously increase that arch height to provide a better biomechanical function. And then again, this is where it comes down to, an examination, as well as, a lot of times x-rays for these are, if you have deformity that maybe is more severe, or it includes the ankle joint. If you're starting to get tipping of your ankle joint, a lot of times high arch can cause a varus of the ankle joint, and a flat foot can cause more of a valgus of the ankle joint, where you start getting tipping in there. And in those types of settings, these are sort of the beginning stages of treatment for that, or an ankle foot orthosis or an AFO. You can have prefab, you can have custom. The blue one up here is known as a Ritchie brace, and then the bottom right is known as an Arizona brace. And again, those are custom molded to your foot to help maintain a sort of a neutral ankle. Shoes. This is not an exhaustive list by any means. I would say these are kind of the most recommended. Brooks, Asics, Hoka, Ultra, Rika, Strikers, or Skechers, and New Balance. Again, not an exhaustive list. With how expensive shoes have become these days, if you've been in clinic, you'll recognize that I recommend these types of shoes, but I don't necessarily say, hey, go buy a Brooks Adrenaline. What works for one person might not necessarily work for the next person. And with shoes being $120, $130, $150, what have you, it's, I would rather you go in and try some based on a recommendation of brand. Most of these brands, these are shoes that are typically recommended as good shoes. Certainly, they have other styles as well, but these are kind of the most common recommended ones. So They're up there. Rika's is a women's only, fairly newer as far as from what I've heard, but I've had some great reviews from them, from people wearing them in clinic and as well as online, kind of seeing, some of the reviews of them. Skechers also have some great slip-ins. So again, this goes back to as you're aging with the arthritis setting in, prior surgeries, prior knee, prior hip, old injuries that, that kind of go along with age. Some people just don't have the ability to get down to their feet and tie their shoes or, have difficulty with shoes. There are some great slip-in options, such as the Go Walk and the Contour Foam from Skechers. Other brands make slip-ins or slide-ins as well, but these are just kind of good options for sort of easy in, easy out that still provide some of that cushioning need and that structural support. So how often do you replace this? I would say this is another thing with stretching that we don't do enough. It does kind of depend on the number of steps you take in a day, your weight, the surface of your activity mainly. But most of the time we recommend every 6 to 9 months for casual walkers. And if you're much more active or much more aggressive ground, such as concrete, unfinished concrete, that would be typically every 3 to 6 months. And you can prolong this obviously if you have multiple pairs of shoes that you're switching between, or if you have a work shoe and then you do a lot of activity in sort of a sport or a walk shoe, at night, you could certainly elongate the lifespan of those. But those are kind of the general recommendations. And again, finding the right fit. Not only does it have to be the right width and length, but you should notice that your heel is nice and stable and snug in the heel. You don't want that sort of sliding front to back or side to side. This certainly can help prevent blisters and callousing as well. Plenty of room for a widening of the foot as you age. Again, a lot of elder people have, history of bunions or sort of flat feet. Maybe they were in high heels for a long time and now they've got a big bunion, and it significantly widens the front of the foot. So most of the shoes, as you'll recognize here, are if we did a deep dive into each one, pretty much all these are wide toe box shoes, not wide shoes. I think that's another misconception is you'll hear you need a wide shoe. And what we're actually referring to is a wide toe box or the front of the foot. We're not actually referring to the width of the midfoot, and for the most part, some people do obviously need a wider midfoot, but we're particularly looking at not compressing the toes together. And then there should be enough cushion for shock absorption, but certainly not too much squishiness for instability. So as we said before, some people who are elderly that can go barefoot and don't have pain with it do actually benefit from not having extreme cushioning all the time. And actually having too much squishiness can actually be a problem from an instability standpoint. You'll notice a lot of, marathon runners in those types of shoes are extremely cushiony because most runners at that pace outside of a sprint are more of a heel strike. And with that many heel strikes within a short period of time, that's a lot of shock absorption that's needed. But for somebody who's elderly on a day-to-day basis, I would absolutely not recommend like a marathon running or a competing shoe for them on a daily basis, because that heel can actually be too soft. So we'll kind of go into some, diabetes and kind of, how it affects the feet and sort of some of the common complications. So here's a nice slide kind of demonstrating some of the common things that we see in the clinic every day. And this is, tingling, burning, pain in the feet. This doesn't necessarily need to be diabetes when we're talking, peripheral neuropathy. Peripheral neuropathy can be caused by medications. We see it quite frequently with chemotherapy. There's a lot of different things that do cause that. Alcoholism, real high levels of alcohol use can certainly cause neuropathy as well. I would say diabetes and neuropathy are probably the two most common. Change in color or temperature of your feet can mean that you have some poor vascular flow. Sometimes that is a clot where that would come on much more rapidly. Sometimes it's much slower. There's things like Raynaud's disease. So, that's not specific to diabetes, but again, something that we see quite common. Again, dry, cracked skin on your feet, loss of the feeling or your inability to feel, or sense heat or cold or even, small objects if you step on them. There's a lot of times if you have neuropathy, you come into the clinic and, you either didn't know you had a wound or you didn't know you had a small cut on your foot. It's very common. Thick yellow toenails, again, that can happen with diabetes. It's not always a fungal infection. loss of hair on your toes, feet, and lower legs. Again, that's one of those signs we're looking for from a blood flow standpoint. Fungal infection, again, such as athlete's foot between your toes. You have sort of a dysregulation, again, of sweat glands and that we'll get into later, but that can lead to cracks in between your toes, and that can lead to fungal infections in athlete's foot. Ingrown nails, again, we know even just as you age, these can become more common with nail changes. So ingrown nails, or sores, ulcers, blisters, infections. There's a lot that can happen with diabetes. So why does diabetes cause problems? It's the elevated blood sugars that cause damage, and we're going to get a little sciencey here, but it causes something called glycosylation of proteins, and it leads to these AGEs, these ages, and they build up over time in the tissue, and they sort of affect the normal protein structure and function, and it ends up leading to almost rigidity in the tissues. So some common areas of damage would again be the eyes, the kidneys, and nerves and blood vessels. This isn't an exhaustive list, as we'll go through here. Damage to nerves. This autonomic neuropathy can affect a lot of different, can affect the heart, can affect the lungs, and can affect your GI tract. There's a lot of implications with autonomic neuropathy that happens due to that long-standing diabetes. In this feet specifically, this affects the appropriate sweating and oil gland function. And this is why we see diabetics with these dry, cracked feet. And again, those dry, cracked feet can introduce bacteria, can introduce fungus, and lead to a lot bigger complications down the line. Peripheral neuropathy is, again, kind of a broad term, but it's damage to nerves, which can lead to numbness, tingling, burning, diffuse pain, and even weakness. Muscles that lose appropriate innervation from nerves or sensation from nerves actually become weak. The muscle tissue sort of becomes fatty. So a lot of times, if we're looking at an MRI of somebody who's been a long-term diabetic, we'll see what's known as fat infiltration and sort of fatty changes within the muscle. And again, that's due to this poor sort of nerve supply, which wreaks havoc. This loss in sensation to the feet, again, can lead to wounds. Wounds lead to infection, and they can ultimately lead to severe deformity via Charcot neuroarthropathy is kind of the main thing that we're looking down here at the bottom picture, where you end up getting sort of micro trauma that you don't feel because of the neuropathy. That micro trauma causes increased blood flow. It starts to wash out these joints. You can have small, minor fractures. And again, it's just this sort of repeat process until what eventually happens is you end up with a rocker bottom deformity, is what we call that, where your foot essentially collapses. And now you can imagine in that setting that when you don't feel that, and you don't know that you have a big prominence on the bottom of your foot, that can certainly lead to a lot of issues and a lot of infections, and ultimately admission for, hospital IV antibiotics and a lot of times surgery. So you're more likely to develop this peripheral neuropathy if you have an A1C over 7. That's why anybody that comes in for an annual diabetic exam, I ask, what were your most recent A1C? What was the highest it's been? When's your next one? What's your follow-up been with your primary care provider? It's very important because A1C is sort of a 3-month, it is a 3-month sort of monitor or average of what your blood sugars have been. So A1C over 7, as well as other risk factors such as smoking, kidney disease, alcohol use, and high blood pressure can sort of expedite the peripheral neuropathy or worsen it. Some common tests that we utilize, especially in clinic, would be the Sens-Weinstein monofilament test. That's sort of that fishing line test. It's a very specific gram or weight to it, and there's a very specific amount of pressure that you put into it. Your inability to feel that, as well as vibration, is sort of how we diagnose that you have neuropathy. It's not just, hey, do you have tingling? Hey, do you have numbness? We can actually pinpoint. And in certain settings, you'll see specific nerve patterns that will be sort of insufficient versus others. And then there's nerve conduction testing and electromyography. These are lab tests that are ordered. Again, nerve conduction test, and they test both the sensory nerves as well as your innervation to your muscles. They see what the amplitude of the electrical signal looks like, and they can sort of test between certain sections to see, you have an overall decreased sensation or decreased appropriate volume of the nerve. And again, with neuropathy, peripheral neuropathy due to diabetes or alcohol or, chemotherapy, things like that, it tends to be symmetric and bilateral, meaning it's both sides tends to be in the same sort of intensity or same amount bilateral. As well as with diabetics, we sort of call it stocking glove pattern. It tends to be in the tips of the fingers. You start losing that inability to tell sort of what an object is, or that real fine motor touch. And then again, as well as in the feet, with the inability to sort of feel. There's also arterial damage, and arterial damage is sort of the mainstay of why the nerves as well. So that those ages that we talked about, they build up in nerves as well, which damage them. But a lot of the damage also comes from arterial damage. So you get this thickening of what's known as the media, which is the inner portion of the wall of the artery. There's three layers to your artery. And it can lead to decreased blood flow in small vessels, especially out in those real small vessels out in the foot. And poor blood flow, again, reduces healing potential, can result in non-healing ulcers. Obviously quite severe would be more gangrene, but we certainly do see shiny, sort of thin skin, as well as nail changes just from poor blood flow. And then again, that poor blood flow to nerves contributes to that worsening sensation. So we're talking diabetes type 2 specifically here. Prevention is the best medicine. Consistent follow-up with a primary care provider, lifestyle and diet changes, diabetes and nutrition education, and sometimes endocrinology to sort of manage everything depending on what else is going on in your health. Neuropathy treatments, again, it kind of depends on what it is specifically that we're talking. If we're talking specifically for diabetes here, this would be something for painful neuropathy. Burning sensation neuropathy, like gabapentin, pregabalin, Cymbalta. There's neuromuscular electrical stimulator devices, different basically foot plates that you can put your feet on that provide different electrical stimulation. Some studies have shown that those can increase some blood flow, and which in turn increases the activity and the volume of the nerve. Spinal cord stimulators. These would be something that would be implanted in your spine if you have real significant painful neuropathy. And then physical therapy as well, because again, when you start losing sensation, you lose the ability to tell where exactly your foot is in space. You end up with more toe scrunching, really trying to grab the ground. And then again, this is worsened with poor eyesight and systemic diseases and arthritis, and there's a lot of different things. But if it's an early on and it's due to sort of vague sensation, we can certainly utilize physical therapy for balance issues. And then blood flow, it really depends on the severity, the location of the decreased flow. A specialist consultation would absolutely be required for that, to further kind of evaluate if any advanced testing is needed or if any intervention is possible, from that side of things. Diabetes and surgery. So again, all this happens in diabetics. So the risk is that increased blood sugar, especially over 7.5, has been shown to increase your infection. It can delay skin and bone healing and elective surgery. There's also special considerations for anesthesia and sort of medications to use, before, during, and after surgery. Again, diabetics understand that they have, a lot of times now we have continuous glucose monitors and we have pumps, so the same things happen in surgery. You have to make sure your blood sugar stay at a certain level, and again, the reason why people end up higher sometimes, I feel like if you were in the hospital, it'd be, low blood sugar, overdoing it on insulin or a medication that can lower your blood sugar is certainly far more dangerous from a health standpoint and death standpoint, a risk than a, slightly elevated. But again, long-term elevation can lead to all these things that we just talked about. So some good habits just for diabetics kind of specifically, but anyone in general, daily foot checks. If you're able to, they do make mirrors, you can get a handle with a small mirror on it that allows you to sort of see the bottom of your feet if you're unable to, or if you don't have somebody that can check them for you. I always recommend white socks. You'll hear me, if you're in clinic, you'll hear this a lot. The importance of the white sock is that, again, if you can't feel your feet, sometimes the first sign that something's gone wrong or there's something open on your foot is that you'll see drainage, drop of blood from a blister or a wound or something that you maybe didn't know because you couldn't feel it or couldn't see it. Again, we know that diabetics will have cracked heels, dry skin. So a daily moisturizer really helps prevent those cracks and fissures before they, open too far and let sort of bacteria in. Diabetic inserts. This is one where it's specific to diabetics. These are custom molded. They're ordered and certified by your primary care provider or endocrinologist, basically whoever's managing your diabetes. But think of these similar to custom orthotics for the regular population. Except the goal isn't necessarily, they still have arch control, but the goal of these is to have a material called plastizote that matches very closely to what the sort of plasticity of your skin is and sort of the pliability of skin. So it's almost, sounds kind of gross, but it's almost like standing on an orthotic made of skin. And the point of that is to decrease these pressure sites before they become wounds. So again, pressure sites on the bottom of your feet from fat pad atrophy, decreased sensation. You're going to heal poorly because your blood sugar is elevated, and you may have cracks in the skin causing bacteria to get in. So really the mainstay is to have these diabetic inserts, as well as specific diabetic shoes as well, but you don't necessarily need to have those specifically. So it's kind of a general overview, I would say, of, kind of general foot healing. Again, the importance on balance, for diabetes, it's daily foot checks. It's, making sure you have close follow-up, maintaining that blood sugar. A lot of times that neuropathy, when it does set in, if it's something that's been there long term, there is very low likelihood of that resolving or, being treated necessarily. A lot of times when you're treating painful neuropathy or burning neuropathy, you are basically trading it for numbness with either one of those spinal stimulators or a medication, which certainly have different side effects. So big thing again is prevention.